is from Harvard, great surgeon and great scientist also. And she will discuss about neuromonitoring of the cavernous sinus, which is definitely key for this type of surgery. We've seen it with the cases shown before. The risk of those surgeries is significant. So having great monitoring is definitely great. Thank you, Linda.
Thank you so much for organizing this, and what a pleasure and honor to join this group on the cavernous sinus. Great. I wanted to touch about the evolving techniques for neuromonitoring the cavernous sinus surgery. As the previous lectures have highlighted, of course, anatomy is the basis of everything that we do, especially in the cavernous sinus when there is risk everywhere, as we both in the cavernous sinus, to the cavernous sinus, and through the cavernous sinus. But for those who venture there, having an adjunct, having a GPS to that road can often be helpful. And neuromonitoring, I think, is one of the powerful tools that we have. The classic modes of neuromonitoring would be broken into two categories: that of monitoring, which is to assessment of the anatomic and functional integrity of cranial nerves and other neural structures, as well as mapping, which is the interrogation of upcoming risks in those neural structures. In the broad overview of the general neuromonitoring categories that we use in daily life in neurosurgery include the monitoring of somatosensory evoked potentials, motor evoked potentials, including for supratentorial and infratentorial surgery, that of the cranial nerves, most commonly measuring EMG responses as we directly stimulate a nerve, but also trigeminal somatosensory evoked potentials, corticobulbar motor evoked potentials, BEARS, amongst others, and increasing kind of interest and I think experience in the various reflex circuits that run through the brainstem from the cranial nerves, which also provide a powerful set of tools, especially in cavernous sinus surgeries. So I'll delve into some of these in more detail one by one. First, this is an illustration of the traditional monitoring modalities that I think the world at large has the most experience with, including SSEPs, motor evoked potentials, BEARS for both cranial nerve 8, but also as a coarse estimate of brainstem integrity, and EMGs. In the cavernous sinus, cranial nerves 3, 4, 5, 6 are particularly keen. But sometimes individuals who use these express frustration at either false positive or false negative artifacts. In our experience, a couple of maneuvers have helped us clean up the sensitivity and specificity of our signals. Taking the oculomotor nerve as a first example, this is an illustration of subdermal electrodes placed into the superior rectus. Another common location would be the inferior rectus. The rationale for perhaps a superiorly placed electrode, which is just sliding underneath the orbital rim as if sliding a central line underneath the clavicle, is if one wanted sensitivity more than specificity. For example, identifying the global gestalt of capturing both superior rectus and the superior oblique, 3 and 4, in a single electrode. Putting in the inferior rectus allows individuals to segregate the superior oblique, or 4, from the inferior rectus, or 3, for those who want specificity. We found that the use of insulated electrodes significantly improves specificity by reducing far field potentials, and also, especially if one were to move towards cortically evoked motor evoked potentials, becomes essential in that category. For the abducens nerve, especially when concurrently run with high density coverage of 3, 4, 5, and 7, a common place to put the ground electrode, of course, the electrode itself is placed into the lateral rectus, but the ground is often placed just lateral to it, somewhere nearby. By placing that ground to the contralateral side, we feel that it reduces cross-contamination artifacts from ipsilateral facial responses and allows greater distinction of these. Another point that was recently made by the Mayo Group in an elegant publication in Journal of Neurosurgery is that the belly of the rectus muscle is about 25 millimeters from the lip of the orbital rim. And so using a longer electrode, about 25 millimeters, gives better responses. And we've also verified that in our experience as well. Moving to the trigeminal nerve, which is particularly intimate with the cavernous sinus, both on the outside and the entryway and in various directions. The most common perception of the trigeminal nerve for most folks is looking for V3 and EMG responses. But the trigeminal SSCPs, which were actually first introduced several decades ago, can provide a powerful adjunct, along with cortically evoked or cortical bulbar motor evoked potentials for V3. And these days, increasing experience with a number of trigeminal-based reflexes add to the armamentarium of assessing for specific branches of the trigeminal nerve, as well as their integrity with other kind of brainstem counterparts. And so these, I think, add a layer of sensitivity, especially in more complex lesions of the cavernous sinus and beyond. Cortical bulbar motor evoked potentials first gained, I think, reputation and increasing experience starting from about 20 years ago with the report of their great role, especially in vestibular schwannoma surgery. They are best described for the facial nerve, specifically stimulating the cortex and recording from the face through the loop of the entire pathway from the cortical representation of the face through the brainstem and then out through the facial nerve itself. And for some individuals, cortical bulbar motor evoked potentials for the seventh nerve may be even more sensitive than EMGs or other sort of pathologic responses that could be observed during vestibular schwannoma surgery. Why this is relevant to the cavernous sinus is because cortically evoked motor evoked potentials can, in theory and in practice, be evoked for any motor muscle related to the face, including V3, 6, 7, 10, 11, 12. Now, one will quickly point out that there is no cortical representation for the extraocular muscles in terms of 3 and 6. And so when running these responses for cortically evoked motor evoked potentials from the scalp or the top of the head, likely this is stimulating the nuclei and not the cortex, and then subsequently being recorded through the peripheral extraocular muscles. However, I think as a surgeon, regardless of what it is stimulating, as long as it is through that kind of network or pathway arc, then it provides an additional tool for us to assessing integrity. So that monitoring aspect beyond mapping of the nerves, when we actually are able to get our probe on it, is really, I think, a helpful adjunct. We looked at cortical bulbar motor evoked potentials because, and we're, did a systematic review of all publications for it. And across the 80 publications that we could find to date, it was great to see that they are represented from all around the world, and that there is increasing experience from many, many great centers, but really mostly focused on the facial nerve still. You can see some experience with other branches, with only, I think, one paper or so published on cortical bulbar motor evoked potentials as applied to the fifth nerve. That the majority of these experiences do relate to the brain, skull base or posterior fossa CP angle. However, there's also some controversy when it comes to the use of cortical bulbar or cortically evoked motor evoked potentials. For one, even the title of what this type of motor evoked potential should be called varies. So this is a word salad map of every possible designation that we found across the papers. And you can see that many, many different terms exist across the literature with very little homogeneity or standardization. The methodology of applying cortically evoked motor evoked potentials also varies. Whether folks use subdermal electrodes versus pegs, insulated versus non-insulated, hemispheric stimulation montages versus interhemispheric, and then the type of stimulation parameters and how they detect artifact using a single double train and or not. It really is all over the map. that probably in part then corresponds to the varying performance that we see across the literature and across different centers. We hear animated discussions in some conferences for individuals who are either pro or against the use of corticobulbar motor evoked potentials. And you can see that the sensitivity or specificity across these major muscle groups are really quite scattered. For us in our team, we spent the last 5 years optimizing corticobulbar motor evoked potentials for our uses, and really have derived the most consistent, I would say almost perfect consistency results with a combination of these 3 strategies, which is using an interhemispheric stimulation with a linked quadrupolar setup, most commonly used for motor evoked potentials, but we now apply that for the corticobulbar motor evoked potential setup, having very tight medial clustering of the stimulation electrodes, and critically using insulated recording electrodes. Having these 3 things together give us really a dramatic improvement in the monitoring responses. And so putting that together, this is an example of for using insulated electrodes for 3 and 6. You can see that insulated electrodes are a little bit more floppy and thin than the subdermal electrodes that we're perhaps more used to. In this particular case, I chose to use the superior rectus and going a little bit more medial to capture both superior rectus as well as superior oblique. Again, looking for sensitivity rather than specificity. Doing the inferior rectus is a similar strategy. Likewise, in cranial nerve 6, using a longer electrode, which is not illustrated here, can be very, very useful for improving the detection. And that's just very simply sliding that to the side of the lateral rectus. You can see it only takes a couple of seconds to insert this, and really can be done by anyone. Protecting the globe with a finger, spacing out the tips of the insulated electrodes because they are a bit more floppy so that they don't touch, and then inserting it in, just sliding it along the side of the lateral orbit, and going from there. When it goes beyond sort of the monitoring for the integrity of the function, mapping is another critical tool. We are most used to this in cranial nerve related surgery, including the cavernous sinus, by using often a stimulator that has some sort of tip that allows electrical conduction. This applies to the brainstem and for the other sorts of areas that we do mapping, including in the corticospinal tract supratentorially. An alternative that has gained a lot of traction in supratentorial intraaxial surgery is to use a monopolar stimulating suction, such that both the tumor resection and the continuous interrogation of the critical structure, whether it's a nerve or the corticospinal tract, can happen simultaneously. And so for many people, there's different ways of doing this. For us, the monitoring physiologist allows to tell us exactly when they hear something at the exact stimulus there. Complementary to these classical sort of techniques, I think, is an increasing experience and interest in brainstem reflexes. And this is powerful, especially for cavernous sinus surgery, because many of these rely on the 5th nerve, including V1, V3. And so I'll highlight this in an example coming up. So this is a cavernous sinus meningioma that I'll just quickly broach, not for the sake of the surgery, which was already beautifully discussed, but the sake of what potential modalities do I find useful in a tumor like this that is clearly within the cavernous sinus. This is a young woman who presented with increasing extraocular movement dysfunction in that left eye, as well as eye pain. And you can see the hyperostotic anteroclinoid and the engulfment of her related nerves. In this particular case, I used the trigeminal SSCPs to assess for V1 to V3, EMGs for the third V3, 6, also 7, but related to the cavernous sinus portion, cortically evoked motor evoked potentials for 3, V3, 6, and then as well as SSCPs and MEPs given the encasement of the carotid artery. The extent of the resection, is at least through the transcranial approach segment of this, is really limited in some ways for me by the adherence to the vessels, but I think overall we achieved the goals of surgery. But most reassuringly for this patient is that with the appropriate monitoring and mapping, we're able to significantly improve her extraocular movements despite the encasement by the tumor. You can see the preoperative motility duction measurements versus they're almost perfect on the early postoperative visual exam. Another common example that we might encounter in terms of cavernous sinus tumor surgery would be trigeminal sternomas. And trigeminal sternomas, especially large ones for us, we've had increasingly appreciation for not just using trigeminal SSCPs, V1, V2, V3, or EMG for V3, but also incorporating some of these brainstem reflexes. You can see in this particular patient who presented with facial numbness in mostly the V2 and V3 distribution. During her surgery, her trigeminal SSCPs were mostly stable, but V1 took a 30% decline at the end of resection. Her blink reflex actually also diminished, and post-op, her V2 and V3 improved, but her V1 was more numb than pre-op. And so, a lot of these modalities we're still gaining experience in, but I think collectively with the body of experts around the world who are increasingly performing these surgeries, I think we have a lot of opportunity to experiment and improve our validity and experiences with these sort of more evolving monitoring and mapping techniques. All of this work is done with my two dedicated neurophysiologists, Matt and Vitaly, who enable me to venture to territory that I otherwise would be hesitant about. So thank you so much.
Okay. Thank you, Linda. Can I make a question to you? So